On behalf of the AMA and our Committee on Health Information Technology, I want to welcome you to the session on Medical Machine Learning 101. Throughout the session, you'll be hearing from Dr. Herbert Chase, a professor of medicine and biomedical informatics at the Columbia University Department of Biomedical Informatics, and from Dr. Ravi Parikh, the assistant professor of medical ethics and health policy and medicine at the Perelman School of Medicine. At the end, you'll also be hearing from Andrew Alexander, a member of the Committee on Health Information Technology, who will be asking these speakers a few questions submitted by medical students. With that, let me hand it off to Dr. Chase, who can get us started.
So this will be a short overview of machine learning in medicine. Today's learning objectives, which we should be able to accomplish, are to help you understand what machine learning actually is, that you can provide examples of how machine learning is used in medicine. You can describe how the machine learns and develops models, and then define supervised and unsupervised learning. So let's start off with the definition of machine learning. What is machine learning? At its simplest, it's algorithms that are used to model data. And the data, of course, in this case, is patient data. The machine identifies patterns in the data, and then it uses the patterns to create a model. A key aspect of machine learning is that it continuously improves itself by weighing the data. It goes back over the data and says, well, maybe this piece of data is more important than that piece of data in terms of establishing the model. And the goal, of course, is to come up with the best model that the investigator is seeking. And this is done miraculously with minimal human intervention. The machine literally learns on its own. That's why we call it machine learning. And it continually improves itself. Let's talk about some examples of where machine learning is important and visit the patient data that's stored in the electronic health record. There is a ton, as you're all aware, as medical students, there's a ton of electronic health record patient data. And we use machines to try to come up with some ideas from the patient data. We use the machine learning algorithms. I'll go over a couple in a minute. And with those algorithms and the outcomes, we can build clinical decision support tools that you will see in the electronic health record. There may be predictive tools that will be displayed, and I'll give you an example in a few minutes. We also use machine learning algorithms for discovery by looking at the patient data. We may unmask or reveal some previously unknown aspect of medical care. Oh, and a key, of course, as I've already mentioned, is that the machine learning algorithms continuously improve themselves by going back over the data. Here are three examples of machine learning algorithms that we use to generate important predictors and tools for medical care. We have an algorithm called classification, which we use in diagnosis. Can the machine develop a model that it can classify a patient as to either having a disease or not having a disease? An example would be multiple sclerosis, where the machine could look through the notes and say, this patient is likely to have multiple sclerosis or not likely to have multiple sclerosis. This is a traditional classification. We also have predictive algorithms, and we could try answering the question, can we predict if a patient with chronic kidney disease will need dialysis in 5 years? This obviously helps in management. And lastly, another popular algorithm in machine learning is clustering. We presume that a patient who phenotypically has the same disease as another patient might actually not have the same disease, that if you broke it down, there are subtypes of the disease. And we could use clustering to ask, are there various subgroups of patients with endometriosis? And that would help us tailor management. This is drilling down a little bit on how we actually build a machine model. So we'll start out with the need to build a predictive model and answer the question, will the patient need dialysis in 5 years? We have two cohorts. We have a cohort of patients who had chronic kidney disease and they ended up 5 years later with dialysis. This is obviously retrospective. Their data is stored in the electronic health record and we can access it. We then established another cohort of very similar patients with chronic kidney disease who 5 years later did not need dialysis. And then we collect data in these columns that in this case, reflect the function of the kidney, creatinine, calcium, bicarbonate, hemoglobin, etc. And then we have the machine use the values in both cohorts of those who needed dialysis and didn't need dialysis, the training on these two spreadsheets, if you will, and the machine develops a predictive model that will look at these values, these attributes, and say, this patient is likely to need dialysis, or this patient is not likely to need dialysis. So any of you can do this on your computer or laptop. All you need is data, an Excel spreadsheet, and a couple of algorithms that you can pull off the web. So this would be a classic prediction model, and we use this all the time in various capacities, and I'll review some of those in a minute. You can imagine this predictive model button being on a decision support tool in the electronic health record. This is actually a screenshot of one that we had at Columbia for several years. Harvard has one that's outstanding, that in the EHR that the physicians use, they click the kidney disease button and they see a prediction button, and it will tell the physician, based on the lab data that has been accumulated in the data warehouse, it will tell the physician what the probability is of having to be on dialysis in 5 years. This is obviously very important to the managing of the patient. And if the probability is high, the physician can be aggressive in the treatment of the kidney disease and high blood pressure or whatever. And if the probability is low, the physician can sort of stay away from the patient, leave them alone, and not be too aggressive. Now, the predictive model that I just showed you was based on known features, and we call this supervised learning, where we, the physicians, tell the machine what features to look at. We just discussed them: creatinine, bicarbonate, calcium, and hemoglobin. I know all your medical students, you know how the kidney works. Kidney regulates a number of different functions. And we've told the machine, as I showed you in those spreadsheets, we've told the machine what features to look at. But the reality is that there are many features that are predictive that we don't know about. We don't know everything, far from it. And the other approach that has gained tremendous popularity and is very important in machine learning is what we call unsupervised learning. That we hypothesize that there are features that we, the physicians, don't know about that would be useful in a predictive model. And it could be something like the profession of the patient, of the patient. Maybe they worked in a factory that had heavy metals in the atmosphere. Maybe their zip code is important because their church group goes around helping them stick to their medicine regimen. The point is that the EHR, which has hundreds of different attributes and thousands of different values, can all be mined. This is classic data mining in an unsupervised way to make the prediction model better. And there are many examples in the literature now of how this approach has dramatically improved the prediction for coronary artery disease, heart failure, and many other chronic conditions. I want to end with just highlighting a couple of successes in machine learning that are already incorporated into practice. Diagnosis, I've already mentioned, is a key area of machine learning. And there's now a diabetic retinopathy machine that can look at the scans of the patient and determine with incredible accuracy whether or not they have diabetic retinopathy, which means that the typical diabetic patient does not need to be referred directly to an ophthalmologist. They can have the scan using the machine and then, if necessary, be sent to an ophthalmologist for treatment. Lung cancer screening has become incredibly accurate. In some cases, the machine is more accurate than seasoned radiologists. Prediction is also very important. Psychiatrists have spent the last couple of years, this is very recent, where they use machine learning, and the data they use are the words in the notes of the patients. There's no lab test for suicidal risk, the way there might be for creatinine for chronic kidney disease. So the machine looks at the actual signs and symptoms written by the physicians in the notes and then builds a predictive model. It's been very successful. And lastly, and maybe you've already seen this on your clinical rotations, there are sepsis predictors that are very accurate. It monitors live, so to speak, blood pressure, temperature, respiratory rate, all the things that you would worry about when you thought a patient might have sepsis. and comes up with a prediction, and a bell goes off if the probability goes up over a certain level. So I think hopefully we've achieved the learning objectives of this talk. We've defined machine learning. We gave examples of how machine learning is used in medicine. We've described how the machine learns and develops models and keeps improving on itself. And lastly, we defined supervised and unsupervised learning. Thank you. And if you have any further questions, feel free to email me.
All right, I'll get started. Thanks, Herb, and thanks to the AMA Medical Student Section for inviting me to this talk. My name is Ravi Parikh. I'm going to be chatting with you today about bias in machine learning in medicine. These are my disclosures. And so I'm hoping that today, by the end of the talk, we'll be able to do 4 things. Define algorithm bias, provide an example of a biased algorithm in medicine, explain why machine learning may be biased, and then identify strategies to potentially help address some of this bias. So first, let's just start with the fact that bias in machine learning is a problem, and even beyond healthcare. When you think about one area where artificial intelligence and machine learning has really taken hold, it's facial recognition technology. Many companies have invested in facial recognition technology to try to identify potential suspects at the scene of a crime, or for marketing purposes with groups like Facebook. While this technology has really taken hold, one of the key things that's been recognized in facial recognition technology over the past 4 to 5 years is that many of these technologies could be biased, systematically mischaracterizing risk for particular subgroups, notably people of color. This has been a big problem and has led many companies, including IBM, to completely abandon facial recognition technology from a lot of their day-to-day operations, because it's just really difficult to eliminate a lot of this bias from the inherent ways that this technology operates. Now, when you think about why facial recognition technology may be biased, there's a variety of factors, including underrepresenting minority faces when it comes to actually training the algorithm, but also a variety of other factors relating to how the algorithm actually works. And I think a lot of these lessons are generalizable to how we think about bias in healthcare and for healthcare machine learning. So what is algorithm bias? Well, algorithm bias really tries to answer the question, does an algorithm systematically mischaracterize risk for a certain group of individuals? Algorithm fairness has been well characterized in a variety of fields, notably criminal justice, banking loan applications, and like I mentioned, facial recognition technology. And the implications are big. When you think about a biased criminal justice algorithm, suppose an algorithm is being used to identify a perpetrator at the scene of a crime, a facial recognition technology, for example. Well, it's been shown that individual algorithms may systematically overestimate risk of criminal activity for African American faces, whereas underestimating risk of criminal activity for non-Hispanic white faces. And so this becomes really difficult when you're thinking about implementing these techs at the scene of a crime, when you might unwittingly and mistakenly implicate a minority individual at the scene of a crime. And I think that becomes a real problem. Across industries, African Americans appear to be particularly disadvantaged by algorithm unfairness, and that applies to healthcare as well. So why is machine learning biased? Well, Dr. Chase just chatted with you about what it takes to go into a machine learning algorithm, and I kind of boil it down into 3 distinct items that you need to specify for a supervised machine learning algorithm, for example. You need to specify your population that goes into the algorithm, and from that population, you derive a series of variables. And you use those variables, in the case of a predictive algorithm, to help predict an outcome. Well, any amount of those 3 steps could be biased and could generate bias in the context of the algorithm. The population, the variables themselves, or the outcome could all be biased. And I'm going to highlight some examples of each of those, but they all sort of boil down to the underlying fact that a lot of the way that we deliver healthcare is biased, and that's reinforced in each of these 3 steps. So first, we often use biased populations to train a machine learning algorithm that could reinforce bias. Here's an example, the Framingham risk score, which is one of the most common risk scores we use to predict cardiovascular event risk. And it's been used for a variety of purposes for over 5 decades. The population, though, that the Framingham risk score was developed on was from Framingham, Massachusetts, an overwhelmingly non-Hispanic white population. And it's been shown that when you try to apply the Framingham risk score to minority groups, that the predicted risk of a cardiovascular event from the Framingham risk score is nearly 20% lower for minorities, including African Americans, than for non-Hispanic white individuals, despite them having similar characteristics. And you can see here a lot of the risk factors that go into the Framingham risk score. Their association with cardiovascular risk really varies a lot between different minority populations. So when we don't include representative populations to train the algorithm, that algorithm could be biased. Another reason is maybe the variables that we're using to train the model could be biased as well. Here you see some work that we've done with the risk score used at the Veterans Administration, the VA Care Assessment Needs Score, which is used to predict, among other things, a veteran's risk of 1-year mortality. While we train the algorithm on an entire cohort that includes many different races, most of the algorithms, most of the variables that are seen as important by the algorithm are sort of dominated by the predominant group in that population, notably white individuals. When we actually boil down and look at the risk factors within the algorithm that are most important for predicting mortality within specific races, we find that the variables that are important for African Americans in terms of predicting mortality oftentimes look very different than the variables that are used to predict mortality for white individuals. However, because white individuals are most of the cohort, a lot of what's in the CAN score ends up looking like the variables that are important for white individuals. That could be another mechanism of bias. A third factor is that we often use biased outcomes to train the model. Here you see the output from a seminal paper that came out in 2019 in the journal Science that used a risk stratification algorithm from a large commercial insurer to try to predict clinical risk. And what these investigators did, which was really elegant, was that they looked at scores between African American and white individuals across the entire insurer population. And they found that at a given score, African Americans were sicker than white individuals, meaning that to qualify for a given care management program flagged by the algorithm, African Americans were usually sicker and were usually in more need of the program. Why that was, it actually happened because the outcome that the algorithm was trying to predict turned out to be cost, which can be lower for African Americans in healthcare, despite the fact that African Americans are sicker. It actually wasn't being used to predict clinical risk, but instead cost. And so cost in this case was a biased outcome for a variety of factors, notably the fact that African American individuals tend to underutilize the health system compared to how sick they are. And underlying all of this is the fact that healthcare itself could be biased. Think about a situation where you're trying to design a machine learning algorithm to predict someone's risk of dying when they're diagnosed with cancer. Well, we know that, for example, someone's genetic and molecular information is really important for predicting someone's risk. However, it's also well known that African Americans are systematically less likely to receive a molecular and genetic test, even when you control for their risk. And that can be because oftentimes we as healthcare providers underuse genetic and molecular testing for African Americans. But the algorithm doesn't know that. It just sees someone without a lack of genetic and molecular testing information and thinks, well, that person doesn't have any mutations to think about, and may underestimate risk for those individuals. It's been well known that these situations occur and that the presence of laboratory orders are oftentimes really important for predicting risk. And hence, if you're less likely to get a lab order or a genetic molecular testing order, then you might be deemed less at risk by the algorithm. So how do we address this? Well, one, we can identify bias and identify potentially flawed decision-making in real time using machine learning. Two, we can use unbiased data sources, data that we think is coming in without having pre-existing biases baked into it. And three, We can track algorithm outputs from our machine learning algorithms continuously to monitor for the potential of bias, since sometimes it's difficult to anticipate it. I'll just leave you with a closing thought, is that we've focused a lot on why machine learning might be biased. And certainly the algorithms themselves could be biased. But the way that we apply it could be used to help address bias. We ran a randomized trial using a machine learning tool to help flag potential patients who might be appropriate for end-of-life care conversations in our cancer center. And we found that the algorithm-based intervention led to a disproportionately greater effect in conversations among minority communities, African Americans, Asians, and Hispanics, oftentimes because providers weren't having these conversations with these communities to begin with for a variety of pre-existing biases or heuristics, and the algorithm could help provide a little bit of a nudge to have a conversation for individuals who are truly at risk using a data-driven format. So these are the learning objectives that I hope we've addressed in this short talk, and I'm happy to answer any questions by email, but thank you for the opportunity.
Okay, thank you both for all this information. So I have gathered some questions from medical students regarding machine learning. One of these questions is, how do we know that we can trust the results that we get from machine learning when we are practicing?
So I can take that one with regard to some of the trust. And I think that one of the key things to be aware of, if say you're on the wards and you're encountering an algorithm prediction, from whether it's one of the sepsis alerts that Herb was talking about, or any other types of predictions that don't even come from a machine learning algorithm, is one, you as clinicians have a tremendous amount of intuition that the algorithm is never going to see. And so I tend to treat algorithms as a distinct data point, in addition to a variety of other data points that you're seeing in practice, whether they be someone's laboratory test result orders. But arguably, one of the most important things is how the patient looks in front of you, and sometimes the algorithm doesn't see that. So I think it's important to view these type of outputs as a series of data points rather than the end-all be-all of how you're going to make your clinical decisions. I think the other thing is, when you see a machine learning algorithm, is to really take a step back and think about, where did this algorithm come from? What population was it tested in? What outcome is it trying to predict? And does it apply to this specific clinical situation? I can't tell you the number of times that we've seen a lot of algorithms published in the literature that perform quite well, but really apply to a specific clinical situation. And so it's our job as physicians to go back and make sure that we're really applying that algorithm in the right way. For example, we're applying it to individuals who are at risk from a pulmonary embolism or a blood clot in the lung, and not individuals who are at risk for a heart attack. We're trying to predict a heart attack risk. So avoiding that creep of different types of machine learning tools into different clinical situations is really important as well.
Thank you. So I have another question.
If I can just add, I just want to add to that, which is you as medical students and residents and faculty, you're entitled to hit the pause button before you respond to something. And I think that's something that is often something that trainees avoid. They're running around being told what to do, but you've put in a lot of hard work, and it's okay for you to hit the pause button. A couple of medical students told me last week that when the sepsis alert goes off in the electronic health record that we have at Columbia, basically everybody ignores it because they don't believe it. It's black box. It was delivered with the electronic health record. Nobody's tested out its sensitivity and specificity. So again, hit the pause button. And as you just heard, then decide whether or not this applies to a patient, and it's a data point.
All right. Thank you both for that response. I have another submitted question, one that's a bit of an elephant in the room. The question is, could machine learning take away some of our jobs in the future?
That comes up all the time whenever I give a lecture to any group of medical students. There's no question that imaging, radiology, pathology, dermatology is a specialty that has been particularly successful using machine learning. So think about the a cancer diagnosis machine that I mentioned in my talk. But the fact remains that the machine will probably be rigged to be very sensitive. You don't want to miss the cancers. But as a result of that, the specificity is going to be lower and there'll be false positives. And I think that we need the next generation of radiologists will be operating at a higher level. They'll be overseeing the cases that are being referred to them by the machine and making sure that you don't over biopsy a patient because of a false positive. So I think the workforce will just be the same as it's always been, and the opportunities will be, but you'll be operating at a higher level. And I think that actually will make the profession to some extent more interesting. You're not going to be looking at film after film after film that ends up being negative. I think the other thing that I'd like to discuss is what is the limitation of a machine versus a human. And I have two comments about that. The first is that humans are analog and machines work on digital information. There are aspects of humans that cannot be picked up by a machine. It could be something that is in their room, you know, the way they're interacting with the nurses, the smell in the room. There are all these signs and signals that a physician pays attention to that a machine will never pay attention to. And the other aspect in terms of decision making is the machine will render an optimal path, perhaps, but it's only the physician and the patient that are going to be able to figure out what's best for the patient. Humans have this capacity, it's called theory of mind. They have this capacity to sort of know what the other person's thinking, and the best physicians sort of know what their patients are thinking. I don't see a machine ever gaining that ability, and humans will always be at the interface of looking at the suggestion, thank you very much, and now I'm going to act accordingly. Maybe the machine says, don't give these two drugs together because they'll interact, and the physician may say, well, you know, the risk of not taking the two drugs together is higher than the risk of the interaction. So they'll always need us. We can always pull the plug if necessary.
Yeah, if I could just make one additional point to those great points that Herb made. Imagine yourself as a patient. Like if you were hearing that, a machine was going to be diagnosing your lung cancer rather than a human, even if there was some data that the machine could be accurate, would you be interested in that? And I would imagine that a lot of patients wouldn't be. There's still a huge demand for a human element to how we practice medicine that's never going to be replaced by machines. And I think too often we've been thinking about these things as adversarial, human versus machine, when the real purpose of a machine is to collaborate with a human. And I think that really ignored the potential for human machine collaborations to help improve the diagnosis of disease. For example, radiologists overseeing teams of machines that are kind of screening initial CAT scans where a radiologist can add on to improve the diagnosis of certain imaging. In our trial that I mentioned, where we used the machine learning to help spur advanced care planning end of life conversations, what we found wasn't just that clinicians were doing more conversations because the machine prompted it. They were doing more conversations in aggregate because the machine was prompting some accurate patients, but they were more in tune to other accurate patients that the machine wasn't identifying. So these collaborations, I think, are where we're going to work with. And the good thing about that is that shouldn't involve any job loss from physicians. It should involve just a higher efficiency of how we do things.
All right. Thank you. I believe that is all the time we have for this session. Dr. Chase, Dr. Parikh, thank you both for taking the time to be here and give us a session on machine learning.
Thank you.
Thank you.